Yeah, good evening all. So first of all, I would thank Dr. Shivani, Dr. Ravi Doshi, and entire team CCI who has given us opportunity to talk upon much less talk topic that is parasomnias and narcolepsy. When we display ourselves as sleep specialists, we do come across such patients. Yeah, most of the patients are being treated by the neurologists and psychiatrists, but we do have some role for that. Today we have esteemed panelist Dr. Murali Mohan, who requires no introduction. He's from Bangalore. Dr. Mohammed Raheem Hussain from Hyderabad. Dr. Tony from Kottayam, and Dr. Dinesh Chouksey, who is a neurologist from Indore. I welcome you all, the esteemed panelists. First, we'll
Thank
go to the first topic, which would be taken by Dr. Mohammed Hussain. This is about the narcolepsy, which we as a pulmonologist do see very frequently. We can
Good evening, friends. Thank you, Dr. Deepak, for the kind introduction. I'm Dr. Mohammad Rahim Hussain, Professor and HOD Respiratory Medicine. I would like to thank CCI Central Committee for giving this opportunity. So, our webinar is on parasomnias. Parasomnias are a group of disorders characterized by abnormal movements during sleep and behavior. So, in that, narcolepsy is of particular importance. Incidence is 0.02% to 0.05% worldwide, and it is most common between 10 to 30 years with no age prediction. And Moen pathophysiology is because of hypocretin deficiency. There are two types, type 1 and type 2. Type 1 has more than 90% deficiency, whereas type 2, which is not associated with cataplexy, it has only mild reduce or near normal levels. And there is also genetic predisposition, HLA-DQ B1 predisposition, and autoimmune mechanisms are postulated, which are supposed to be triggered by infections such as streptococcus, influenza. All these things are not proven, which leads to destruction of hypocretin producing neurons at the hypothalamus. And so what happens? Hypocretin is mainly responsible for REM sleep inhibition during wakefulness. So if this hypocretin is lost, this REM sleep and wakefulness cycle is not maintained. So patient will have daytime, they will have REM symptoms like muscle weakness, excessive sleepiness, sleep paralysis, hallucinations, and all those things. And so there are two types of narcolepsy, one with cataplexy. Cataplexy means sudden onset of muscle weakness with emotions like laughter, crying, etc. Without cataplexy is type 2. And so primary symptoms are excessive daytime sleepiness, of course, which can be there in other disorders. And in addition to it, sleep paralysis and cataplexy. Cataplexy means loss of muscle tone with excessive emotions like laughter, crying. And some people will have hallucinations while going to sleep, which is called hypnagogic, or while awakening from sleep, it is called hypnopompic. And of course, these lead to automated behavior and disrupted sleep quality of life. And how you will diagnose? First, you have to do nocturnal polysomnography. So why you have to do? You have to rule out associated conditions of excessive daytime sleepiness like OSA and all those things, and idiopathic hypersomnia. And one more thing, we will record sleep latency as well as REM onset, which I will come to later in my later slides. So diagnostic criteria is polysomnography. After polysomnography, you have to go for multiple sleep latency test. Here, what you will do, you will perform sleep during daytime around 10 o'clock, 12 o'clock, 2, 4, and 6, 2 hours interval. Patient will be asked to remain in a quiet room, and patient should fall asleep within 15 to 20 minutes. And if patient does not fall asleep, then test is abandoned. And after patient falls asleep, you have to note the onset of REM sleep. REM sleep occurs within 15 minutes, then it is considered as positive. Otherwise, after 20 minutes, again test is abandoned. And one more thing, hypocretin level measurement in CSF. So ICSD diagnostic criteria, which is very well defined based on clinical suspicion, and after that based on polysomnography and multiple sleep latency. Here they will have irresistible desire to sleep and daytime napses lasting for at least 3 months associated with sleep paralysis. Plus, if it is associated with cataplexy, which is narcolepsy type 1. Without cataplexy, it is narcolepsy type 2. But most important thing is this one, positive MSLT, in which sleep latency is reduced for less than 8 minutes. Normally, it is above 15 minutes, and two or more periods of sleep onset REM means REM sleep occurs immediately within 15 minutes of falling asleep. Normal person, it will take at least 60 to 90 minutes. So here REM onset is very much earlier. So that's why patient will have paralysis, all those things, because REM is intruding into awake time sleep. And one more thing, you have to measure hypocretin levels, which is not essential for narcolepsy type 2. And you have to rule out other causes of hypersomnolence, as I have told you, like obstructive sleep apnea, idiopathic hypersomnolence syndrome, and other drugs, of course. So most important is a multiple sleep latency test. Here you will measure daytime sleepiness. 5 different times you have conducted at 10 o'clock, 12 o'clock, 2, 4 and 6 in the daytime. And here average sleep latency you will calculate from all 5 different time period, and you will measure average. If it is less than 8 minutes and REM sleep is occurring within 15 minutes, then it is considered a positive test. And one more guideline says in multiple sleep latency test, if even if one REM sleep is there, but in nocturnal polysomnography, there also you have one, then you can consider it as positive and diagnostic. So preparation, whatever applies to polysomnography, same patient should not take alcohol, all those things, and he should remain in calm room. So diagnostic criteria, as I have already discussed, clinical criteria plus based on multiple sleep latency, where mean sleep latency should be less than 8 minutes and at least 2 events of sleep onset REM period, which means REM sleep occurs within 15 minutes of onset of sleep. And if it is narcolepsy type 1, you have to measure hypocretin levels, which is less than 110 picograms per ml. And narcolepsy type 2, there will not be much deficiency. So coming to management, mostly it is behavioral management. So you have to counsel the patient. If they are involved in high risk professions, they should avoid driving, all those things, and lifestyle modifications. And in between, they should take scheduled naps like lunchtime, all those things. And pharmacological management like modafinil or modafinil, and one more new drug like solriamfetol, which acts on dopamine and noradrenaline receptors, and of course sodium oxybate for excessive daytime sleepiness and cataplexy. Even antidepressants like venlafaxine and fluoxetine is used. But one emerging promising therapy which is still under trial is orexin 2 receptor antagonist like daridorexant. Here, the main mechanism of narcolepsy is because of hyposecretin deficiency, which is related to orexin receptors. So, they have formulated these drugs which acts on orexin 2 receptors. Okay, thank you.
Good evening, everyone. First of all, I would like to thank Chess Council of India for giving me an opportunity to discuss about a very big topic, parasomnia diagnosis and management. So I'm just giving an overview related to it because parasomnia basket is very containing lots of things in it, and that it would be really difficult to discuss each and everything in very short span of time. So few important things related to diagnosis, clinical history, and that management part I'm going to discuss today. So As we all know that sleep is very important related to that, because disturbed sleep can lead to functional disability of an individual, and along with that so many psychological issues related to day-to-day life, and it really create a burden to a family and society and an individual. So, sleep-wake disorders like insomnia disorder, these are a different one, hypersomnolence disorder, narcolepsy, neurodegenerative disorder type, breathing-related sleep, circadian rhythm, parasomnias, different REM and REM, restless leg syndrome, common group of that movement disorder, and substance and medication-induced sleep disorders. So this is just so what are the parasomnias? As we all know that a group of sleep disorders that are characterized by abnormal when someone is going to sleep during sleep and awaken from that sleep. So parasomnias occur alone or in the setting of some sort of problems like related to trauma, psychiatric illness, other sleep-related disorders, and some neurodegenerative disorders like Parkinson's disease and spinocerebellar ataxia is one of them. So NREM and REM parasomnias may occur together when then we call it as a parasomnia overlap syndrome. As I told previously, that complete history and diagnostic workup, including that polysomnography, is important to rule out the different related syndromes, types, and reach to a conclusive diagnosis for a specific management of that particular parasomnia. So, NREM parasomnias more seen in children specifically as compared to adult, and parasomnias more frequently related to that, like some sort of underlying neurological problems to them, psychiatric issues like ADHD also, and some developmental issues in the children's causing that type of parasomnias. So parasomnias, NREM, sleep arousal, like confusional arousal, sleepwalking, sleep terror. These are the few types of NREM sleep arousal disorders. REM sleep related parasomnias like nightmare disorder and REM sleep behavior disorder. These are the different types classified based on the type of sleep durations. So it is a disease of arousal. There is a confusional arousal, sleepwalking terror, and confusional arousal mostly mildest form less than 5 years of the age group of the children seen partially awaken from the slow wave sleep and just sit up, look like confused, like back down, and again resumes the sleep. So these are the confusional arousal mostly seen in that stage 2, 3 and REM sleep. Pathophysiologically, motor cortex is active and inactive. That prefrontal cortex, which is suppressing that sort of thing, they are inactive regions and mid-temporal lobe. And during these patients, SPAC study showing that there is an increased blood flow in the cerebellum and the posterior cingulate cortex, and decreased flow in the frontoparietal cortex in these patients. So, what other environmental factors lead to this? That reduce sleep, disturb sleep, tiredness, stress, lack of slow wave sleeps, leading to these generation of problem. Rebound sleep with prolonged slow wave sleep, deep sleep are the reasons for that. So risk factors, again, environmental, few drugs like antidepressants, mirtazapine, benzodiazepine, non-benzodiazepine sedative like zolpidem. These are the drugs which commonly prescribed, but they can cause such problems. Sleep deprivations, sleep-wake cycle disruptions, and sort of stress, physiological, psychological, and fatigue leads to development of this type of problem. Sleepwalking, family history is strongly present in that, and if there is both parents, then it is more common in the children's. Sleep terrors, first degree relatives, and there are 10 times of chance of developing that sleep terrors in those childs. Exact mechanism is still under evaluation. Sleepwalking episodes, there are frequent episodes rising from bed, walking around, and these are the purposeful movement patients have, blank staring face, relative unresponsive to communication during that time, and difficult awakening during that period. Sleep terror, abrupt terror arousal, panic scream, intense fear, autonomic hyperactivity is there, relatively unresponsive to efforts to comfort while parents doing this just to relax their child. So clinical course onset mostly seen in that NREM parasomnias in children's, and it decreases with the ongoing age, and in adults that fresh onset NREM parasomnias could be due to obstructive sleep apnea, nocturnal seizures, drug induced. These are the possible things we have to look while taking history and working for these patients. Sleep terror, we have to see that children with some sort of any psychopathology is there. Adult, there must be a traumatic experience, some psychiatric comorbidity in these patients. So, how we diagnose? Simply, we have to first take a detailed history. By history, we can classify that particular NREM, parasomnias, and by investigation, we can find it out with video recording and the polysomnography in these patients. So, different stages of sleep during polysomnography by seeing different changes in EEG, electrocardiogram, EMG. At that first stage, that there is a change in from alpha transition to theta waves when there is a transitional phase, stage one, and there is decreased eye movement and decreased tone in the muscles. In stage two of NREM sleep, there we know that K complexes and sleep spindles are present, and in EMG there is a low tonic activity is there. Stage three, most of the that EEG consists of delta waves. These are the slow, large amplitude, slow waves, 3 to 4 hertz frequency. Most of the record contains delta waves in that, and EMG showing low tonic activity. And the another sleep variety is the REM sleep, in which there are EEG showing low voltage mixed type of activities in EEG, and along with that, rapid eye movements are seen, like forth and back eye movements in electrocardiogram, and EMG showing that atonia with phasic twitches. This is a classical thing which is by which we can differentiate REM sleep. There is atonia is present. These are the different graphs showing that EEG, how it look like during awake state, and REM, there's a low voltage mixed type of waves, and in NREM, these are slow delta waves. EMG in REM sleep, there's a loss of tone in muscles, and there's a EOG changes, and there is in NREM sleep, it is like very much flattened sort of. So, for NREM parasomnias, reassurance is very important. Detailed discuss and reassured about that, how to counsel and how to manage that sleep hygiene. All those things are very important. Reduce that any sort of environmental risk factors, and safety around that bedside is also very important. And during episode, patient if awake, redirect and try to relax techniques with them, and few patients get benefit with that clonazepam and melatonin in these patients. And different type of REM sleep related parasomnias. REM sleep parasomnias are REM sleep behavior disorder, nightmare disorder, and recurrent isolated sleep paralysis. These are the three things come in that group. And it is more common in male patients, and age group is 50 or more than 50 age group is like there, and it is also linked with that neurodegenerative disorders like alpha synucleinopathies, like Parkinson disease, having that pathophysiology of alpha synucleinopathies, Lewy body dementia, and multiple system atrophy. All these come in this group of disorders, neurodegenerative disorders, and that RBD is seen so many years before development of these specific disease. It is very important to take a detailed history and evaluation related to it and find it out the chances of developing in future all these disorders. Along with that, other parasomnias like nightmare, sleep paralysis, sleep-related eating disorder, sleepwalking, these are the different percentages related to that. And what are the essential point of REM sleep behavior disorder? Like that sleep paralysis, which is present during the REM sleep, it is totally lost, and there are the different muscles which by which EMG activity is showing, like tibialis anterior muscle in both the lower limbs and the flexor digitorum superficialis on both the upper limbs, showing some sort of muscular activity, EMG activity during that RBD patient episodes. And these patients have that absence of sleep paralysis. They are dream enacting behavior, like complex behavior, and mostly in a second half of the night it is seen, and people storytelling like memory and unaware of the surroundings in these patients. So by that, it is a dream enacting behavior in these patients, complex behaviors, sometimes running, jumping, leaping on the bed. They mostly and that on the bed, punching, slapping, and injuries to the self and the other can be there. There is a vocalization also in these patients. So prevalence-wise, it is seen in approximately 0.5%, more in male age group more than 50 years. Course is progressive in these patients associated with neurodegenerative disorders. And these RBD symptoms improves when that some any type of disease symptoms are coming in these patients, like Parkinson's disease, MSA, and gradually that RBD symptoms gradually decreasing in these patients. So, other say some drugs can unmask or say cause RBD type of problem, like TCA, SNRI, beta blockers can lead to this, and also associated with alcohol and barbiturate withdrawal lead to that REM sleep behavior disorder. As already discussed, that recurrent episodes in these patients, vocalization, complex motor behavior in these patients, and say later part of that life. And after that subsidence of episode, upon awakening, they are alert and oriented. This is a very important point related to that. And there is no atonia or polysomnography EMG related to synucleopathy, and we have to exclude that some sort of precipitating causing drugs or substance in these patients. Diagnostic markers, we have to diagnose with that polysomnography video along with that, and during that EMG showing present of muscle tone, which is normally not seen in REM sleep. So, treatment wise, RBD, identify and remove the offending agent if it is there, and the modification of sleep environment, safety of self and the bed partner is very important. When these patients, mattress could be on floor, have that safety to avoid injury, protection from that window. Patient may have disturbed jumping and aggressive behavior in these, and remove the sharp objects, and sometimes people can use that customized pressurized bed alarm, and to just to aware about that episodes in these patients and give that prevention to them. Treatment wise, clonazepam and melatonin, these are the two drugs which are helpful and alleviate these symptoms of the RBD and restore that atonia related to that REM sleep and improves the symptoms. What are the sleep hygienes? As we all know that do's like regular hours bedtime and rising to fix the schedule and avoid daytime sleepiness, and to have a good circadian rhythm of sleep. Take a light snack if you're hungry patient, and late evening, regular exercises, and a cool and dark, quiet bedroom enhance that initiation of the sleep, and avoid that worried or something like that, and current era, avoid that social media and mobile, or say late night awakening with that social media and televisions. These things can precipitate that these problems. So maintain a sleep hygiene is one of the good aspect of managing these patients. So how we differentiate majorly between RBD and NREM parasomnia, as we discussed, that it is more common in younger age group, NREM parasomnias, and it is more common in adult male and older male, and late night. These are the timings, and it is NREM in early stage entry stage is there, and there is a significant difference in polysomnography in these patients. So one another differential diagnosis in RBD and that nocturnal frontal lobe epilepsy. These are also almost similar type of in that, but the episodes of nocturnal frontal lobe epilepsy are they're a little bit transient, and there is a stereotype of behavior in these patients, and with that frontal lobe epilepsy score in RBD is 0, it is more than 3, and a typical finding on that EMG presence of tone in that RBD, as in which is not there in that nocturnal frontal lobe epilepsy. Along with that, typical spike wave or sharp wave epileptiform discharges in EEG seen in these patients, and there is a long history in these patients because sometimes genetically also that frontal lobe epilepsy. So, few drugs, substances lead to that sleepwalking by the alcohol, and RVD, as we discussed, provoked by that some TCIs, caffeine, and antidepressant drugs. And nightmare can be seen with that those who are taking levodopa and the beta blocker. So these are the substances we have to consider when taking history, and try to avoid as one of the part of the treatment of these patients. And for this just a very important thing, because every day, every time, and there are a lot of things which are in a very gray areas, and difficult to differentiate each of them. Few points are there to differentiate with each of them. With the help of investigation, we can conclude, and there's a very important to conclude a diagnosis of a typical type of sleep-related behavioral, motor, or abnormal transient episodes, and then we can manage these patients correctly. Another thing is that restless leg syndrome, periodic limb movements, are the movement disorder seen in that these patients, and they are having that very urge to move around in upper limb and lower limb during the sleep timings, and with the specific treatment they can relieve by that, and history is very important in these patients. So my take home message in these patients to first step that to management, like severity assessment is very important, identifying and treat the comorbid sleep disorders in these patients, and that find out that any inducing agents, and that surrounding atmosphere environment for the safety in these patients are very important. NREM parasomnia are treated by identifying and reversing the condition, and try to do sleep hygiene in these patients, apply very well counsel, and when we are not offering that medication to patient and relative, and they are taking this as a advice, but I strongly believe that tell them that this is not that advice, it is the first treatment that you should follow, how to maintain sleep hygiene, and it is come as a prescription treatment part, rather not only that treatment drug is the only treatment. So RBD with violent dream and acting behavior and related to that Parkinson disease, very important to find it out later on, and it goes with that disease particular any synucleinopathy's development, and it is treated by the clonazepam and high dose melatonin. So these are the just an overview. There are a lot of sleep-related disorders, and they are differently evaluation is are there. One of them narcolepsy is there, but since this is a very big basket, and I have to restrict my talk to some extent, so I'll just give an overview related to that. Thank you very much.
Yeah, we had an excellent talk by Dr. Mohammed Hussain and Dr. Dinesh Chouksey. They rightly pointed on the narcolepsy and different parasomnias. Remembering about my friend, my school friend, during the prayer times, he used to have sudden falls. So now I can say that that was narcolepsy. So we'll go to Dr. Murli Mohan regarding, sir, what is narcolepsy and how are we able to differentiate it from the different sleep disorders, what we see regularly?
Yeah, so narcolepsy, you've just heard an excellent talk. It's a chronic sleep disorder, and it's a very frightening disorder in some ways. The person's sleep-wake cycle is disturbed, and obviously that leads to huge problems. Dr. Deepak, you were talking about your friend who suddenly would, fall asleep. So this is one of the characteristics: excessive daytime sleepiness, but also suddenly sudden weakness of the muscles in the type with cataplexy, and patients with this kind of excessive daytime sleepiness often feel very drowsy and fatigued during the day. But when they go to sleep, they can often wake up feeling completely refreshed. And this is not like obstructive sleep apnea, for example, where they go to sleep, when they wake up, they still feel unrefreshed. And this is one of the differences between narcolepsy and some of these other sleep disorders. The other sleep disorders, for example, don't have cataplexy. What is cataplexy? It's a sudden loss of muscle tone, and the person can suddenly collapse or feel extremely weak. And sometimes this can be triggered by, laughter, anger, very strong emotions. The other very worrying thing is that they have a sudden irresistible urge to sleep during the day. And when they go to sleep, when they're falling asleep or when they wake up, sometimes they have these episodes of sleep paralysis. And you can have hallucinations. And there are two types described. Hypnagogic, when you're falling asleep, you can have very vivid hallucinations. And as one is waking up, you can have the so-called hypnopompic hallucination. So waking up, going to sleep, both you can have these problems. The typical feature is excessive daytime sleepiness, which which we've seen in obstructive sleep apnea, for example. But as I said earlier, these short naps can sometimes make them feel suddenly much better. And then again, they can go back and lapse into a state of excessive sleepiness. So that's one of the differences you find. You also don't find the typical snoring that people with obstructive sleep apnea have. You may or may not have the other physical features that we often see in patients with obstructive sleep apnea. So it's important to maintain this difference. Just yesterday, I had a patient, we've been treating him as obstructive sleep apnea, obesity, hyperventilation. I've asked him to bring his sleep study that was done recently so we can see if he's having the SORMs that Dr. Hussain described earlier, because I have a strong suspicion that this gentleman has narcolepsy rather than straightforward OSA, OHS. Back to you, Dr.
Right. Yeah, sir, very well explained by you regarding narcolepsy. So, Dr. Hussain, what are different type of narcolepsy? You have already mentioned in your presentation, but and what are the different clinical presentation? How the patient comes to you? We would like to know about the clinical pearls about it.
Of narcolepsy.
Of narcolepsy, yeah.
Yeah. One without cataplexy and one with cataplexy, as Murali Mohan sir has very well described. Here, strong emotions will not precipitate sudden paralytic kind of attack, as you have told one of your friends. Remaining symptoms will be the same: excessive daytime sleepiness. He will go into REM sleep very quickly, and also with decreased sleep latency. Otherwise, there will not be much difference. And if you do hypocretin levels, it will be low. Main cause, as it was hypothesized, it is due to damage to hypocretin neurons in the hypothalamus, leading to hypocretin deficiency.
Right. So one is with cataplexy, that is the muscle tone loss, and one is without it. Dr. Tony, if you can tell about that, how we can diagnose if patient comes down to you, what are you going to tell him, and what are the different type of tests which you will prescribe to them so as to diagnose the narcolepsy?
Hi, good evening, everybody. Am I audible?
Yes.
Yeah, you are well audible.
Yeah. So the issue coming is that when the problem is this is not a single test diagnosis. That is a problem. We have to just go into such a detailed history evaluation. And the problem is with children, it is very difficult to elicit this history. So adult patients, okay, it's an easier way, but usually you have to have the sleep partner also to get the proper history regarding the sleep pattern. Secondly, for children, if the children are sleeping in a separate room, it is difficult to get that history. So the parents should have been sleeping with the child to note what were the points before we come to a analysis of that child or that situation. Now, our speakers have already excellently covered the entire topic. So I'm just going to go very briefly, just touch the points that are the most required. So basically, we have to have a proper clinical evaluation to consider other diseases to be ruled out before we reach narcolepsy. That is usually a last diagnosis. So one is along with that appropriate medical history, appropriate physical examination, and the other diagnostic test. Now, the medical history, what we need to know is that first of all the basic sleep pattern and any other. So as Murali said, if there's an underlying OSA, we have to look at all these issues first. Then only we come to this diagnosis. Then along with that, we do a Epworth sleepiness scale, ESS score, to know how is the exercise between daytime sleepiness. Then also, as usual, the other examination, even diabetes uncontrolled, GERD, all these issues should be tackled before we go into this diagnosis. Now, in the practical diagnostic test, we do a sleep study, a polysomnography, which is an overnight sleep study test where we monitor all the sleep stages and look at how the REM sleep sets in. Then we also have the multiple sleep latency test, where the MSLT, where we have this thing. Hello.
Hey, you're audible.
Yes.
Hello. I'm not. Am I audible?
Yeah, you're not audible. It is getting frozen in between.
Yeah. So now then, along with that, is it breaking? Hello.
Dr. Tony, why don't you switch off the video? Then I think you will have bandwidth for the.
Yeah. I switch off the video. Is it audible?
Yes, you are.
Yeah, you're audible.
Yeah. Okay. So then, along with that, we have to look at. So one is the sleep latency test. Then we go for the hypocretin level, which is a blood test, in which you can know if it is low, then the tendency is more towards narcolepsy. Then another good factor is genetic testing, where we look for the HLA-DQB1 or the 0602 allele. If that is a possibility, then it again pushes towards the same diagnosis. But we cannot do all the tests in the same slot. It has to go by order. But initially, we'll have to describe this to the relatives of the patient before we start the evaluation. And don't forget, we have to do probably a brain MRI, even to look at anything else, any focal issues or anything else is there in the brain. Now, once we reach the diagnostic rate, if we are following the International Classification of Sleep Disorders, the ICSD-3, in that we have to consider that excessive daytime sleepiness, which is persistent sleepiness despite having adequate sleep. Cataplexy, where there is a sudden brief episodes of muscle weakness, often triggered by emotions, as just now we saw Dr. Deepak's friend. Then hypocretin 1 deficiency, which we have to look at for in the CSF also. MSLT results is also if there is a mean sleep latency less than 8 minutes and greater than 2 sleep onset REM periods, then we should consider that diagnosis. But also, very importantly, consider we have to rule out sleep apnea, restless leg syndrome, periodic limb movement disorders, idiopathic hypersomnia, etc. before we come to this diagnosis.
Yeah, very well said, Dr. Mohan. If you can tell me how we are going to go for a MSLT test. Many a times I've seen the people don't know how to go for it and when is to be done and how it's to be done.
So typically we do this after a overnight sleep study, and we keep them in the hospital and we continue the study and we give them repeated episodes of sleep. We wake them up and then again continue to record. And we see how long it takes for sleep to reappear EEG wise. So the first, episode of sleep that the person slips into. And as they told you, if you have a very short latency of sleep again, and this is despite an adequate overnight sleep, that is a very good assessment of the ability to maintain wakefulness. So you do your multiple sleep latencies, as the name tells you. You look for sleep latencies repeatedly. You do it several times. And once you're satisfied with the result, then you can stop the test.
Rightly mentioned. So we are doing in different breaks. Like we are letting patients sleep for like 20-30 minutes. Then we see whether patient is going for a REM sleep or not, and we see for the latency. Correct, sir. So, Dr. Dinesh, good evening. So,
Hi, good evening.
hi. So, I want to know that is there any difference between adult and pediatric narcolepsy, and how different these both present?
Basically, it is say major difference related to that. We say age group. Child little bit jittery, so these might have more hyperactivity during the night time, and they might have that eating disorder associated with ADHD. So the child having this type of more spectrum rather as compared to adult, and they are having less episodes of classical cataplexy as compared to adult, and also having some sort of abnormal as their age group related to that periural chewing type or say coriform type of movement as a part of cataplexy, these the child mostly. And along with that, there is lesser chances of hallucinations in pediatric age group as compared to adults. So these are the some little difference related to that.
Just one point to make, that many a times taking history from the school teachers is also very important. That many times they come to you and tell to the parents that the child is very sleepy, he sleeps during the class, and this I've seen it quite frequently.
Yes,
So,
yes.
yeah. Muliman sir, if you can tell about the pharmacological management of narcolepsy.
Right. So we've already heard that narcolepsy has two components. One is the excessive sleepiness, and the other is the cataplexy part of it that occurs. So we can, look at treating these separately. So if a person has predominantly only the narcolepsy component, what you try and do pharmacologically, there are non-pharmacological treatments also. Pharmacologically is handle this excessive daytime sleepiness. And you can either use first line treatments or you can use second line treatments. First line is usually a monotherapy, and we start with something like modafinil or R-modafinil. You can also use drugs, the newer drugs like pitolisant, tongue twisters. I can't get the name of the next one at all, though I've tried many times. It's solriamfetol. So those are the first line drugs. The advantages and disadvantages of these are, very different. But what we tend to use mostly is modafinil. When you have the cataplexy part of it, then you can add on the oxybate. Sodium oxybate is available, and it's basically a GABA receptor agonist. And if you look at it, the entire sleep thing functions through a few neurotransmitters. You have dopamine, you have norepinephrine, you have GABA. So what we use are combinations or single drugs that work on these receptors. So when you have narcolepsy, cataplexy, what we typically use is sodium oxybate. Now, the problem with sodium oxybate raised a lot of controversy in the West because it was being used as a date rape drug, and therefore has a potential for abuse for the user as well as for people whom they want to abuse it for. So that is the problem with sodium oxybate, but it's a very effective drug. And you can combine it with the other drugs when you have a combination of narcolepsy and cataplexy. So these are some of the drugs that you can use. And I think the psychiatrists also tend to use more of the SNRIs, and you can use venlafaxine and so on. So those are add-on drugs to the basic treatment with either the wakefulness maintaining drugs or the sodium oxybate and related drugs.
Right. Right, sir. So you also mentioned about the non-pharmacological therapy. Dr. Hussain, if you can elaborate on that what are the non-pharmacological therapy which you are going to prescribe to the patient who comes to you with narcolepsy?
Yeah. First, you have to identify what is the precipitating cause. If it is related to antidepressant, because antidepressants are two-way sword. They are useful for treatment as well as they can precipitate. If the thing are ruled out, next is maintenance of sleep hygiene. They have to maintain same sleeping time, wake time consistently, and they have to have in between naps also is also required for narcolepsy patient in between. Otherwise, they will suddenly fall asleep and they may injure themselves. And relaxation techniques like yoga, mindfulness, cognitive behavioral therapy, all those things, and lifestyle modifications if they consume alcohol, smoking, all those things.
Right. So, Dr. Tony, if you can tell, if the patient is left untreated, what are the long-term complications we are going to see in those patients, and what are the hazards which we see in the narcolepsy, untreated narcolepsy patients?
So we have to consider that by many times the patient who comes to us will present with the next stage of disease rather than the primary narcolepsy. So when we are diagnosing some other disease, we have to always look for narcolepsy in the background. So, for example, now obesity is one thing that is easily a complication of narcolepsy because patient becomes lethargic, when tries to be more of a sedentary lifestyle, does not do the exercises or anything like that, and slowly starts developing weight. That obviously will lead to high blood pressure, heart attacks, maybe even a stroke. Now, the sleep-related issues, basically, they have sleepwalking. They can have injuries, falls, accidents can also happen. And sometimes even triggers headaches and migraines also as a background reason. It will be narcolepsy. Now, the long-term implications should also look at the emotional and the psychological complications also. Many a time, depression because of for example, many times or ordinarily it may not be diagnosed easily. So they'll be on other medications for these diseases and they'll be having more and more developing anxiety and mood disorders also. Then along with this, it also affects to the stress levels. Stress again goes back to the weight gain, increases cortisol levels, it also weight gain, brings in an OSA component also into the underlying narcolepsy issue. Now, then with all these things, and when, for example, if they are always sleeping, it will affect the family life, it affects the work lifestyle, and even they end up with a low self-confidence and low self-esteem. So, the problem with the way the disease is diagnosed is we have to go in a step-by-step process. Even we have to also ask for any memory issues, any sort of learning difficulties, or mainly even sleep issues. Now, even career-wise, when you look into the matter, if they're having a job where you have to be in a calm spot, you're relaxed, like maybe then that itself will put them into a tendency to go to sleep. So that will affect the job what they're doing. So they have to have more of an active kind of workspace where they have to either move around a bit for their getting the works done, or they have to have a fixed maybe a possibility a gap for sleeping in between to take some transient rest and come back to work, which is a bit difficult in any continuous profession. So all this can also lead to, and also along with that, in the real life situation is the risk of accidents and the complications related to those accidents, and also with the quality of life overall being reduced. So considering all the factors that it is an entire lifestyle affecting disease, and we should consider that the patient should be comprehensively evaluated if they're suspecting a narcolepsy, that you include a neurologist also in the evaluation. A psychologist also may be required. You have to sometimes in children when pediatrician should be involved, should rule out maybe even other maybe syndromic diseases. So it's a team effort to come to a complete diagnosis for narcolepsy.
So, just to add one case scenario with this, recently I got a patient whose wife told me that whenever they used to get intimate, he used to sleep. So that was one of the point which I came to. They were like planning to go for separation, but me and my psychiatrist friend who referred that patient to me, we discussed and we started on modafinil and other therapies. Presently, he is doing well. So many a times we are sometimes overlooking the cause. We have to take, as you rightly mentioned earlier, also taking a detailed history is very necessary. uh, we talked about the pharmacological therapy. We talked about the non-pharmacological therapy. Dr. Dinesh, can you tell us what are the novel therapies which are available or which are under trials for this narcolepsy treatment? Dr. Dinesh?
Am I audible?
Yeah, you are well audible.
Yeah. So basically, newer drug, as Dr. Murali sir told about that different new drugs acting on the different receptors with having some sort of dopamine and norepinephrine reuptake enhancer. But the thing is that since it is a lateral, say, hypothalamus decreasing neurons or say decrease hypocretin, immunomodulating therapy tried in these patients, but results are not that to good extent related to IVIG therapy. People has used steroid also, some sort of newer drug like rituximab or another monoclonal antibodies. But outcome was not that good in these patients. And another thing is very important that these drugs are not having very good safety profile, also having a lot of complication related to septicemia and all. So immunomodulation has tried in these patients, and in that research work related to that co-use of that transmagnetic stimulation along with that deep brain stimulation, and that to see that TMS efficacy up to go deep with that excitability and that measure by the deep lead of the DBS recorded. So just to see that excitability deep and see that plasticity of the brain can help in a few patients. And this is still limited to the research centers. But the thing is that simultaneous use of that, both of them can lead to some sort of DBS circuit complication related to that, even though that less stimulation, or people also did research work related to that, that it is not very much harmful. So under trial, all these things, but at present, these drugs, I think, would be the, as sir told about that, the combination, as you also told about that combination of drugs that will be beneficial, but or other things are under research and not that yet could result in that.
Right. Even certain trials have mentioned about the gene therapy.
Yes, yes.
Dr. Deepak, can I just add,
Please,
what Dr.
please.
Chouksey said is so right. We still don't know. We tend to treat narcolepsy as one homogeneous kind of thing, or two, narcolepsy and narcolepsy with cataplexy. But if you look at how it occurs, many theories have come forward, one of them being the autoimmune theory, which is why I was talking about, the anti-immunomodulatory therapies. The other, of course, is whether we can replace the orexin deficiency. But all of them have been so far extremely, unclear about what it is. And finally, if you look at the genetics, there are so many different genes described. So as you said, manipulation of the gene may work, but we first need to understand which exact type we are dealing with. We tend to treat them all as one phenotype. But I think once we understand the underlying cause, we'll be able to offer more personalized treatment. Still very far away, I think.
Yeah. Like mentioned. So some of the studies have also mentioned his association with H1N1 also. I don't know whether immunizations can prevent narcolepsy in these patients.
Or immunization can trigger it off. That's the other.
Yeah. The other way around is also correct. So now we'll go for our next part, that is parasomnias. Sir, we'll start from you only. That what are the different parasomnias and how they are classified?
So parasomnias you can classify depending on which phase of sleep they occur. So you have typically the ones which are associated with non-REM sleep. You have those which are associated with REM sleep. There are many other parasomnias which don't fall neatly into one of these categories. And finally, a very important group that I'll talk about a little later are the secondary parasomnias. So when you look at parasomnias which occur in non-REM, typically you have the confusional arousals, you have the sleepwalking and sleep terrors, which often look like these are disorders of arousal. So the person doesn't have a complete arousal from sleep and is half asleep, half awake. So that's when you get these confusional arousals and sleep terrors and sleepwalking. Then you have the disorders with REM sleep. And the classic is REM sleep behavior disorder, where I recently had a patient, husband of a psychiatrist, who would always act out things. He'll be flailing around in sleep right at the onset of sleep. Fairly typical REM sleep behavior disorder. Then there is the sleep paralysis that can occur associated with REM sleep, and you have the nightmare disorders. And you talk about what used to happen. There are some nice descriptions of incubi and succubi. So a woman wakes up feeling there is something pressing on her chest, frightening images, and so on, and they attributed it to a spirit. So that is the nightmare disorder that you come across. And then, of course, you have a whole system of parasomnias where you have sleep enuresis, bedwetting, sleep-related groaning. Just yesterday, I saw a person who was grinding his teeth heavily during sleep. Then there are, of course, sleep-related eating disorders. There are a lot of dissociative disorders associated with sleep, and something called the exploding head syndrome. I've never come across one, so I don't really know what it is like. Dr. Chouksey may, because I think these go more to the neurologists than to us. But what I think is important for us to know, and we may come across more, is that any disorder that affects sleep, causes sleep fragmentation, causes poor sleep, can trigger some parasomnias. And these are called the secondary parasomnias, because primarily you have a sleep-related breathing disorder causing fragmentation of the sleep, and that leads to these secondary parasomnias. So that's important to know. And then there are some disorders which are associated with abnormal sexual behavior, especially associated with OSA-related arousals. So they partly wake up because of the arousal, and they can have abnormal behavior, abnormal movements at these times. The other thing that is important is when patients come with insomnia, they tend to use medications like zolpidem and benzodiazepines and so on. And these have also been associated with various parasomnia. So I think those are important to know, that we should be sure that the medication we are giving is not causing a problem, that a primary sleep-related breathing disorder is not causing the parasomnia. So that would be roughly the classification of parasomnias in a very simple way.
So
Murali,
I
sir, can I
remember,
ask a doubt?
yeah, Dr.
Deepak,
Dr. Tony, tell me.
Yeah, Murali, sir, the patient we spoke about, which you saw yesterday, that when you find the grinding of teeth, would you consider an EEG to rule out seizures also during sleep before we go into further this kind of deep duration of sleep?
We could, but the reason I'm not thinking of it because he's quite arousable, which is why we've been thinking of mostly OSA, OHS. But the ease with which he falls asleep makes me feel we should rule out narcolepsy. I'm not seriously considering epilepsy in him, but that's a good point. I think, I'll probably ask one of my neurology colleagues also to see him. And again, that's a point. All these parasomnias especially should be managed by a multidisciplinary team, a psychiatrist, a neurologist associated with us. And really, we play a minor role in this.
So I remember my first encounter with the parasomnia patient. I was a child when I was posted in the pediatric ward. He used to wake up. He never used to wake up. He used to get up at night, used to eat everybody's stuff, whomsoever was there in the ward, and used to sleep back again. That time, it was like we used to understand that this is another sleep eating disorder. So, as you rightly mentioned about different classification, uh, Dr. Hussain, can you elaborate on the different causes of parasomnias? Sir has mentioned some of the drugs as well, but
Yes, yes.
organic and psychological, both of them, if you can mention
Yes,
those.
yes. Main disorder is related to wakefulness, sleep and wakefulness cycle, because patients with non-REM sleep disorder, they are neither awake nor sleep, because as even our neurologist sir also told, Mulli also told, because of disruption from the frontal motor cortex. So they will have muscle tone will be there, but brain activity will be half. And one more, REM behavior disorder. REM sleep, you will have complete paralysis. Here that plug will be lost. So patient will have hyperactivity, like he can hit the partner, all those things, because of this neural switch mechanism mostly.
The other organic diseases, Dr.
Like,
Chouksey, if you can add on that.
yes. Thank you.
Dr. Dinesh? Yeah, if you can add on the organic causes, what you have mentioned, like Parkinsonism and
Yeah, there are a few causes related to that REM sleep behavior disorder, like synucleinopathies that develop later on, and the basic pathology of insoluble synuclein protein deposition. Later on, they develop MSA, Parkinson disease, and dementia Lewy body. And a few patients might have some sort of brainstem lesions like CP angle tumor or stroke related to that, and autoimmune encephalopathy. Nowadays, that movement disorder with lots of autoimmune phenomena, and they are a good thing in that they are treatable. Previously, we thought that only the symptomatic treatment for these patients, and they will not respond. And over the period of time, they really deteriorated. But in today's era, that like Eglon 5 disease, like LGI1, Casper 2, these are the autoimmune disorder. You can have this type of RBD presentation. And good thing about that RBD, just to know about that in the history, or say you classically find it out that RBD is there. I think only thing, because these are the neurodegenerative diseases, better for these, they can plan for that future DBS if they're going to develop Parkinson disease. Otherwise, this is just information you just treat it, and over the period of time they develop that these neurodegenerative diseases.
And in your practice, what kind of patients come across to you, and how are you able to differentiate whether it is REM related or non-REM related, and how you can differentiate it from the normal sleep, like night terrors, nightmares? How you're going to differentiate from all the parasomnias? If you can elaborate points, you have already mentioned it in your presentation, but the clinical pearls for all of our understanding, if you can tell us that.
Mostly, what I found in my clinical practice is that it is one of the parts. Say those patients came with that Parkinson disease, or they gave that history that 5 years, 7 years back, these type of problems, and now it is decreasing, but they are there as a co-phenomena, as an information, not that as a one of the presenting complaints. Few people like that, say restless leg syndrome and periodic leg movements during sleep. They people come with that classical, say that they are clinical diagnosis, having classical presentation and a history they say about that. So these regularly come across, but that say as I told that about that headache, sort of head bursting side of parasomnias. I never heard as a complaint from a patient, because it is they are just imagination of that something is explosive going on, but not that headache they are complaining, those patients. So our patient is having hypnagogic headache in night. They are mostly elderly people and having a classical time period related in night they develop, and pattern of that in elderly male with hypnagogic headache. So sleep terror, sleep, say other parasomnias. There are a lot of parasomnias are there, but as a primary presentation, their numbers are lesser as compared to the co-phenomena like REM, sleep behavior disorder, and these patients like this.
So, just to mention another patient of mine, about 4 weeks back, this lady had come with so many marks on her wrists. So, when we did her level 1 study, she used to wake up at night and she used to injure herself, and she was not aware of it. And she used to put blame on the husband that he might be doing it. So that was one of the thing which, like the scratch marks, the injury marks. Many a times during sleepwalking as well, we find a lot of marks patient can injure themselves because the patients are not aware of the surroundings. So, Dr. Tony, if you can tell about the how are you going to diagnose those parasomnias? We have differentiated between the REM related and non-REM related. So, what are the steps you are going to take when the patient comes on to you?
Again, we'll have to think, consider same as narcolepsy itself. We'll have to go again for the same points. So we'll have to have a detailed history. We'll look at the sleep studies for the sleep pattern. What is the spouse history or the parents' history regarding the sleep pattern? And the problem is that we have to also, along with that, go do a video PSC. As you rightly said about this difficult patient, when you do a video PSC, you catch these kind of things, abnormal movements, and which are these activities happening. Then you can also go for an actigraphy, in which you have a wearable device to monitor the movement and activity patterns during the sleep. Then also you can do an MSLT to know what is the sleepiness level and how is the sleep onset pattern. An EEG will also help you rule out if there are any sort of underlying seizure disorders which can mimic parasomnias. Now, the specific diagnostic criteria will be the non-rapid eye movement parasomnias, in which there is a confusional arousals, there will be sleepwalking, and deep probably sleep terrors will also be there. Now, diagnostic criteria is there should be episodes occurring during an REM sleep, often with amnesia for the event happening. Now, then there is a REM parasomnias in which you have maybe REM sleep disorders. You can also have in that the episodes occurs during the REM sleep and often with vivid dreams, or they'll be acting out the behavior, executing what they are seeing. So now along with that, so these are the basic idea. The detailed talk was already done earlier. Now also in this, as I said earlier, again consider the same differential diagnosis of sleep apnea, insomnia, restlessness syndrome. All these also should be ruled out. So it's a team effort. Different specialties should coordinate for coming to a diagnosis.
And a lot of your inputs from the family members as well. So, Dr. Murali Mohan sir, again over to you regarding the therapy for the parasomnias. How you are going to approach for the treatment, and what are the pharmacological treatment which are available presently?
Yeah, so compared to narcolepsy, I think the drugs that are used for parasomnias are more familiar. And again, you'd probably want to separate it into non-REM and REM, though a lot of the parasomnias treatment is similar to both. So generally, what you try to do with non-REM parasomnia is use something like melatonin with some benefit. It seems to be more effective in REM parasomnias. The thing that is most often used are the benzodiazepines, and people tend to use clonazepam most. We start with a low dose and titrate it upwards if required. There are, I think, good benefits to clonazepam, but honestly, I don't think there's much difference between any of the benzodiazepines in any condition. So, but we are most familiar with clonazepam, and I think what one should consider is its duration of action, addiction potential. The long-acting ones have greater addiction potential because these are people who are going to take it for a long time. So we have to worry about the side effects also. The other group are the antidepressants. You can use both tricyclic antidepressants or you can use the SSRIs, SNRIs. Again, the effectiveness in REM behavior disorder is probably less, and in all REM parasomnia seems to be less, and it seems to be more useful in the non-REM. And this is probably because it enhances REM sleep, while you don't want that too much in the REM parasomnias. And as an alternate treatment, again, doubtful efficacy, but probably the safest of all is melatonin. So that is one group of drugs that we use for the parasomnias. If you include restless leg syndrome, very often what we have to use is a combination of, when it's intermittent, you can use L-DOPA or, L-DOPA, carbidopa combination, or you can use something like pramipexole. And that seems to be quite effective, and you can push up the doses quite a bit. But people have also tried other things, including clonazepam itself. It gives better quality sleep. There are other drugs that are used. Again, some of these are the worrying part of it is the date rape drugs like roperidol and so on. So you can use drugs singly or you can use combinations. And those who have restless leg syndrome usually benefit from, my general experience has been they tend to seem to do fairly well with pramipexole, which is used more by the neurologist. So I'll hand over to Dr. Dinesh for the next part of it.
Right, Dr. Dinesh, can you put some more light on it and lighten us with those?
Yes, yes. I think then overall that there are a few things that as I told that dual its sword, but melatonin is one of the drug that can be used safely and especially in that RBD patients. And for that, say RLS or PLMD, pramipexole, propinerol, along with gabapentin, we can use. But over the period of time that L-DOPA and that DOPA agonist, there is augmentation effect. So we have to not just see that when patient came that there are problem increasing with that increasing dose. We have to think about that this is augmentation effect, and on that time we have to reduce that dose of that L-DOPA or say DOPA agonist. Along with that, these patients are also having that pathophysiologically iron deficiency. So giving iron for RLS patients also helpful in up to an extent. So therapy-wise, two, three drugs are there that has to be chosen with the proper, say, not in that every time patient came and they are having symptoms, we just have to increase the dose, not the right strategy. Take detailed history and according to that decide. So these are two, three things in management part related to it.
Right. Dr. Hussain, if you can tell about the non-pharmacological therapy which you are going to give to these parasomnia patients.
Again, same thing. Maintenance of sleep hygiene, cognitive behavioral therapy, relaxation techniques, and also proper counseling. And if any smoking, alcohol, anything is there, they should refrain from those things. And even you have to rule out the side effects of some of the antidepressant drugs because they are double-edged sword. They are used for treatment as well as they can cause parasomnias also. And if it is related to, as sir said, secondary parasomnias like OSA related, you have to correct that one, OSA. And lifestyle modifications, more important.
So, do you think that the screen time before sleep also have some effects on parasomnias?
Yes, 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 definitely. Nowadays, after especially after COVID, so many people are complaining. Definitely, they should avoid screen time at least for 1 to 2 hours before sleeping time.
So what I remember, there was one study which showed the reduction in the melatonin secretion once you're seeing the mobile phone or you're seeing watching TV,
Yes,
because those rays are very effective in reducing the melatonin secretion.
melatonin. Yes, yes, yes. Especially after Android and Apple phones. Yeah.
Yeah.
Especially the blue screen effect they talk about, which is
Yes,
the worst form of light for suppressing the melatonin secretion.
yes, yes. Thanks.
So, Dr. Tony, if you can, we were talking about, like, I was talking about my patient who was inflicting injuries to herself. Can you tell about the other potential hazards which we can see in these parasomnia patients and how to address those?
Sleep, eating, also you mentioned. So that is one problem. You get up in the night and you eat during the sleep. So etc. Unknowingly you will gain weight and add to the overall problem. Then also there is violence. It is possible without the patient being aware of it. It can happen to the other partner, and we have to take it in that respect. And many a times, as you yourself told, you have already saved us quite a few marriages by correctly diagnosing the problem for mental discord. So it has to happen as a team process with the family. Then also with that we have the issue regarding the self-injuries. In case the patient has a tendency to say, leave the house or go out of the compound, that is a different problem. And if they're on the escape, falling down from a staircase or banging into something on them, they may end up in a different situation. The partner will find them maybe in a pool of blood when they get up together, hear a scream. So that is a terrifying situation for a family. So it's important from our point of view that we should go into in-depth history to ask these questions for every single patient who comes to us in this regard. And along with that, so as we can say, even the professional complications. In that, what happens is that if they're losing focus from their work or they're getting maybe a wrong way of dealing with machinery, if they're using some in refineries or this kind of major machinery, they forget to switch off something on the time. That's crores of rupees of loss in maybe in a night. So that all will affect their job, their professional competency, their earning capacity. So entire life is will go into a negative cascade if this kind of an issue occurs. Now, another thing is even in sometimes you'll find in assaults happening. So if that assault is a problem, it can come as a forensic case. It can come as a legal issue. So all these matters also we have to take in that stream. The primary problem is that it is not a single person diagnosis. So everyone should remember, please involve a neurologist, involve a psychologist, share the opinion you're taking about the patient, then only come to a diagnosis. Because you will change a life, you can also destroy a life.
You were talking about the legal liabilities. So this patient who is having parasomnia, is he legally liable? Can anybody tell on that?
If the diagnosis is right, then he should go scot-free.
So I didn't get you.
Well, it's a medical disorder, no. He can't be
Yeah.
punished for that.
Okay, right,
That's why the diagnosis has to be right and not under duress.
correct. So, Dr. Dinesh, you were mentioning about that transcranial magnetic stimulation and DBS for the narcolepsy. Does it have any role? And if you can elaborate, what is these techniques which can be used for parasomnias?
As I told previously, it is one of the experimental most of the things people tried and about that because two things are there. The basic, the transcranial magnetic stimulation is superficial cortical layer excitability is there with that pulse and that deep brain stimulation that with the electrode, the deep structures stimulated. So by that single pulse of TMS, by that recording from the DBS electrode is the just related to that cortical hyperexcitability and neuroplasticity in these patients. Does it really helpful for that? Because again, that few drugs are available, but as in narcolepsy, that is still say further better treatment other than drug as a neuromodulation and other newer therapies. And similarly in parasomnia, we are discussing therapeutic options and we are having a very limited sort of thing in that related to that behavioral therapy, counseling, reassurance, and that protective mechanisms along with that few safe drug like benzodiazepine and so about that dependency and lots of other comorbid illnesses leading to continuous use of that is not possible in those patients. So it is still in research, but that few promises with that recordings are there to see that neuroplasticity because brain has developed that neurons and new functioning of that related damage around neurons. So for that assessment, this is only nowadays in research, but not that because DBS is basically for that standard for PD, dystonia, and essential tremors. And people also use for that Alzheimer disease nowadays, experimental for that. And for OCD, TMS is effective. We know that. So combination of both and to assess that cortico-basal ganglionic thalamic circuit excitatory inhibitory pathway leading to these movement disorders and that sleep related problems for that assessment is going on.
Right. Thank you so much. So there is one question regarding MSLT. So it's like how to perform MSLT, what are the diagnostic criteria, and when to consider test negative and when to consider it positive. So any one of the panelists, if they can take this question. Dr. Murliman, sir?
Yeah, so very simply, what you have to do is typically you do it after an overnight sleep study. The person should be prepared appropriately for it. So, for example, they need to avoid stimulants which may interfere with the test. They should be off have control of their anxiety. And as I said, after the full night sleep study, the person is woken up, and then you do several such test procedures. About 5 is what is usually recommended. So the person should be prepared not only to stay overnight, but the whole of the next day. The circumstances should be right. It should not be a brightly lit room. Everything should be appropriate for the person to go to sleep. No noise, no light around. Then what happens is it's done like a sleep study, but then what you look for is how soon, under ideal circumstances, after a full night's sleep, does the person go to sleep as assessed by the EEG. We expect the person to fall asleep within 15 to 20 minutes, and it becomes significant if it is in less than 8 minutes. I think somebody referred to that number earlier also. And if the person has not gone to sleep within 20 minutes, we usually wake them up, give them a gap, and then allow them to sleep again. So if the person has been able to sleep falls asleep within less than 8 minutes more than once, then this is generally taken as a positive test. But obviously, this has to be interpreted in the clinical background. So you should have an idea what is the pretest probability that you're dealing with one of these disorders like narcolepsy, and then interpret it in the light of that. Because these tests are not easy to do, they're not easy to interpret. But when you suspect narcolepsy or one of the idiopathic sleep disorder syndromes, then it's a very good idea to do the MSLT. But it's time consuming and not easy to do.
Yes, sir. We have completed like a lot of clinical things regarding parasomnias and narcolepsy. It's very difficult for a pulmonologist to treat all those. As rightly mentioned by Dr. Tony as well, you require a MDD kind of therapy for them. And once you put like in your designation, if you put a person who is practicing sleep medicine, you do get a lot of patients who, after reading your profile, do come to you for different kind of parasomnias or narcolepsies as well. So we need to know how to diagnose it. I really thank all the panelists for giving their time and also excellent presentations by Dr. Chouksey and Dr. Hussain. And thank you all for being very involved in this discussion. I would request Dr. Ravi Doshi, who has made this complete webinar series regarding the sleep disorders. Over to you, sir.
And very special thanks to Dr. Deepak. Excellent moderation, including sharing your own experiences. That was very useful. Thank you.
Yes, indeed, sir. Over since the first week of December, CCI has organized this sleep course in which we have conducted 5 webinars on exclusively on sleep topics. Started by sleep physiology, then sleep diagnostics, sleep disordered breathing, and there was this webinar today. And me, along with Dr. Shivani Swami, have been given this opportunity to conduct this sleep course guided by Dr. Krishna sir and CVK sir, Dr. Atri, and all the background CCI webinar team. We have been glad that there have been 1100 plus audiences in all the sleep podcast webinars that we have done. So I would like to give a big thanks to the audience, my co-director Dr. Shivani Swami, and especially to all of the all of our colleagues who have contributed their knowledge to help all of this sleep related academic come force, and it will all be there on the CCI YouTube channel for us and students to access for all the time. So a big thanks to everybody, and happy learning.
I think Dr. Shivani's also joined. So thanks, Dr. Shivani.
Yeah. Hello, sir. Good evening, everybody. So, at the outset, I would like to thank everybody, especially everybody who's logged in for all these 5 webinars. It has been a great learning experience for us, not just to coordinate, but also in terms of attending the webinars. There's been so much learning for us also parallelly. So, a big shout out to everybody who's moderated, all the panelists who've participated, taken out their valuable time to, do this. I think we have had an extensive learning experience of sleep itself by all the stalwart faculty. And I would, like Dr. Ravi said, like to thank everybody, Dr. Krishna sir, Dr. Narayana Pradeep, Dr. Ashish sir, Dr. Maske, Dr. Vijay Kumar Chennam Chetty, Dr. Atri, Dr. Kirat, and of course my co-coordinator, without whose help I could not have pulled off any of this, Dr. Dosi. So thanks a lot, everybody, and we are really, really grateful from all of us at CCI that to all the faculty who really took out their precious time and imparted knowledge and shared it with us. So thank you, everyone.
Thank you.
Thank you very much, Chess Council of India. Coordination to help us to arrange this program. Krishna sir, thank you so much.